All right, we'll go ahead and get started. Good afternoon. Welcome to our second event of the Women's Health Lecture Series. I'm Dr. Tony Hong, and along with Dr. Archipoli in the red dress, we're excited to continue our work with the Women's Fund for Health Education and Resiliency. Through our partnership, we've been able to host these very informative health seminars, health lectures covering a range of topics, including health monitoring, anxiety and depression, reproductive health, as well as stress and wellness. Today, our guest is Ms. Vaughn Gilmore from the Menninger Clinic, and her presentation will explore drugs, the brain, and behavior, the reality of addiction and recovery. I mentioned earlier that the presentation is being live streamed and recorded for educational purposes. Please take a moment to silence your cell phones as a courtesy to our viewers and our speaker today. And now I'd like to turn it over and introduce Ms. Debbie Marley from the Women's Fund, and she will give you a little background about the organization and then formally introduce our guest today. Ms. Marley.
Hello, and thank you for coming. We're so appreciative of everyone being here today. You know, the Women's Fund's been around since 1979, and we have been empowering the greater Houston area adolescent girls and women since then. And we do that through our publications, which we have brought some with us today. So if you get the chance to visit our table in the back, please do so. We've published 4 publications. We also educate through seminars like this, lecture series like this, through curriculum-based classes and some smart lunches, brown bags, things to that nature. Last year, we served about 9,000 women and girls and were able to distribute 10,000 of our publications. So we're growing and growing and growing. We also have ample opportunity for volunteers, so if you're interested in that, or if you're interested in doing an internship with us, please sign up at the table in the back, and we would be more than happy to have you aboard with the Women's Fund. So now let me go ahead and introduce our speaker. Vaughn Gilmore. Vaughn is a licensed clinical social worker and a licensed chemical dependency counselor. She is the coordinator of addiction services at the Menninger Clinic, where she leads a team of addiction professionals. Vaughn has worked as a staff social worker and addictions counselor, helping both adult and adolescent patients get on the path to recovery. She integrates evidence-based practices into individual and group therapy interventions for individuals with co-occurring disorders. She has given presentations on a range of topics related to the assessment and treatment of substance use disorders as both mental health and medical professionals. A graduate of Texas Christian University, Vaughn obtained her master's degree in social work from the University of Texas at Arlington. Please welcome Vaughn Gilmore.
Okay. Hello. Can everybody hear me okay? Okay, great. Well, thank you guys for having me this afternoon, and thank you for being here. As my presentation title suggests, I'm going to be talking a little bit about sort of addiction and recovery, and what does that really mean, and really putting that into context, sort of some of the things that you're hearing on the news about the opioid crisis. So what does it really mean when we say people are sort of having these really high overdose rates? Why is that happening? What is kind of some of the science behind that? So that's really kind of what I'd like to focus on today. We will have plenty of time at the end for questions as well. So just to kind of start out with, putting some of this into context of the scope of the problem, right? Again, if you turn on the news, you certainly see, there's just record numbers of people dying from overdose. And the question is, why is this happening, right? Certainly some of this is happening because of synthetic opioids on the market, like fentanyl, that are incredibly dangerous. But there's actually a lot more going on here in terms of the science of what happens in someone's brain when they repeatedly use drugs and alcohol. So I won't be talking specifically about the science of just opioids today. I'll be talking overall about sort of drugs and alcohol and how use alters the brain and then makes recovery very difficult. But much of this is relevant sort of to these statistics and news that we see. Again, putting some of this in context, right? Huge numbers of people dying from overdose related to opioids, and then also putting it into context in terms of alcohol use. Really, 88,000 people in the United States are dying from alcohol-related illness every year, which is, people don't really think about alcohol as much when we think about the consequences of addiction and substance use. And this is costing us billions of dollars sort of as a country. So this is really relevant whether or not you misuse substances or you know someone that does. This is sort of a public health issue. Again, putting some of this in context, the number of people that need substance use treatment versus the number of people actually receiving it. So the majority of people, as you can see, 89% of people that need substance use treatment are not receiving it. And obviously the question in my mind is why, right? Some of this has to do with access to care, availability of treatment, cost of treatment, location of treatment. But I would also argue that a lot of this has to do with stigma. People don't want to ask for help related to substance use. They don't know how to ask for help because there's a lot of stigma still in our society about asking for help. And some of that really goes back to some of the myths we're going to talk about today related to addiction and how people develop addiction. Still to this day, addiction is one of the few diseases that we blame the individual for having, right? We don't blame people for developing cancer or any other chronic health problem, but we do blame people when they develop addiction, and that makes it really hard for people to reach out and ask for help. So the first myth I have here, I hear this all the time, addiction only happens to bad people. In the introduction, they describe that I work with clients who have substance use disorders and families of individuals with substance use disorders. And I hear this one all the time. I can't have a substance use disorder. That only happens to bad people, right? That doesn't happen to people with jobs and families and successful careers. That happens to people, that have been down on their luck. But actually, that's not true. Addiction can happen to anyone. Addiction can happen to anyone, regardless of your background, your race, your ethnicity, your social status, your education. There are certain identifiable risk factors that we know of that can predispose people to addiction. But other than those risk factors, there is no sort of other like bad people or character defects or moral flaws that lead to people developing addiction. So some of the reason that people use substances, and this is important because if we understand why people use substances, we can understand that this is, again, not something that just happens to bad people. Most people, right, 80% of Americans at some point will drink alcohol in their lifetime. 40% of Americans will smoke marijuana at some point in their lifetime. So this happens, but it doesn't have anything to do with character. So some of the reasons that people use drugs and alcohol are for social, right? For enjoyment, for leisure, for fun. It's very much ingrained in a part of our culture and sort of the way that we experience leisure in the United States. Also, some people use drugs and alcohol to cope, right? Sometimes to relax after a hard day. Just listen to people around you. How many times do you hear people say, oh my gosh, I had such a hard day at work. Let's go to happy hour, right? It was such a long week. I need a drink, right? That's coping and social and leisure, right? All reasons that people are using. Conformity, right? Plenty of young people try and use substances because other people are doing it. And plenty of adults use substances because other people are doing it. I can't tell you how many lawyers I've worked with that say, Vaughn, you just don't understand. All lawyers drink heavily, right? So there's a conformity component for adults as well. Experimentation and expansion. Plenty of people use substances because they want to enhance their experience. They think it makes life more enjoyable. It's sort of mind altering, all of these reasons. And no judgment from me about any of these reasons. These are just the reasons. And then the last one is medical treatment. And this is particularly relevant when we think about misuse of prescription medications, because a large portion of people that develop opioid use disorders or sedative use disorders actually started taking those medications for medical reasons. And we'll talk a little bit more about like how that progression happens. But that initial use for most people, as you can see, is pretty benign, right? And they're things that everyone is doing. So again, just to kind of put that in context, the number of alcohol users in the United States, and this is from 2016, the number of people using alcohol versus the number of people using alcohol for binge drinking, which would be 4 or more drinks for women on any given occasion and 5 or more drinks for men on any occasion. And then we get down to people that are heavy alcohol users. And these are the people, both binge drinkers and heavy alcohol users are going to be the ones at risk for health consequences and developing addiction. So the question in a lot of researchers' minds is, why do some people, this many million Americans consume alcohol, right? 80% at some point in their lifetime. Why do some develop an alcohol use disorder or a problem with alcohol and other people don't, right? That's kind of the question that a lot of researchers are trying to answer, and hopefully we have some insights into that. And here is sort of in answering that question, how we think about that progression. So most people start out not using substances at all, right? Hopefully when you're a child and a teenager. And then as a teenager or a young adult, people might move into experimentation, then occasional use and regular use, and then eventually the substance use disorder develops. So if we look at this in terms of like prescription drugs, somebody might be prescribed a medication to take every day for pain following surgery or for a chronic pain issue, and they're using regularly, right? The longer they use regularly, the higher the risk they are of moving from just using that medication as prescribed to developing a dependence on that medication. This process can take a long time for alcohol use, for example. Many people are in that occasional use to regular use period for years and years, and then maybe they have a stressor or something changes in their life. They move into heavy use and then a substance use disorder. So addiction is not something that just kind of happens overnight or that someone chooses. It's really a progression, and we're going to talk a little bit more about some of the changes in the brain that happen during that regular use period that then lead to dependence. Okay, so here we have sort of the dotted line is drug abuse. So you can see this is ages along the bottom. So between ages 15 to 20, a lot of young people are using drugs and alcohol. Many of you in the room probably have used drugs and alcohol, right? So what's the difference? Again, this is sort of the question at hand. Why do some people, this sort of darker line, develop a dependence when so many people are using during this period of time? So this is kind of what we want to get the answer to. What makes some people just higher risk? Again, it doesn't have anything to do with sort of like background or, race or religion or anything like that. There are actually some factors outside of that we know of. And one of them actually has to do with age. So we actually know that the younger somebody starts using drugs and alcohol, the higher their risk for developing a substance use disorder. And a lot of that actually has to do with the developing brain. So we know that in particular, the prefrontal cortex, the part of the brain responsible for decision making, executive functioning, impulse control, isn't done until your mid-20s. So any substance use during that period of time is basically altering or impairing the development of that part of the brain. So even going back, right, even if it's just occasional or regular use, it can impair that sort of process. So we theorize then that is why younger use, right, makes someone at risk for addiction. You can sort of see the statistic here, right? Before the age of 15, 5 times more likely to develop a substance use disorder. So this is one of those controllable risk factors, right? Where we want to stop young people from using drugs during this high risk time. People that wait until age 21 to start drinking have significantly lower risks for developing a problem with substances because their brain is so much closer to being done developed. Just some more statistics about sort of the risk. particularly thinking about marijuana, right? Most people will try to argue with me, well, marijuana is not addictive, like it has a lot of benefits, it's good for you. And I will not argue with you that most people that use marijuana will not develop an issue with marijuana, right? Only 9% of marijuana users will develop a problem with marijuana. So that's a pretty low percentage when we think about it. The problem here is for people that use young, right? So again, we're talking about as teenagers and into young adulthood, that increases to 17%. And then for people that are using daily, that rate goes up to 25 to 50%. So if you have a young person, a teenager or young adult using daily, you can sort of, extrapolate the risk is significantly higher. So yes, for most people, it's not a problem. However, if someone's young and using heavily or regularly, then we see a lot of those impairments in development with memory, impulsivity, decision-making, and then we also see the risk for addiction significantly increase. And this is pretty much sort of the same thing about alcohol use, right? If you wait until 21, it's significantly reduced. So what are some of the other risk factors for addiction that we know of, right? If we go back to that other slide about, many young people using versus the number developing a problem, these are some of the things that we actually have research data on and know can contribute to development of a problem with drugs and alcohol. So on the left-hand side, we have sort of the biological components. The first one being genetics. We actually know that about half of somebody's risk for developing a substance use disorder is genetic. Half, which is a huge percentage. That still means the other half is environmental, right? But about half of somebody's risk. So this has to do with if you have a family member or, not just parents, but grandparents, aunts, uncles, things like that, because we know that some of that risk is transmitted through genetics. The other thing with biology is related to the effect of the drug itself. And again, this has to do with many people might use cocaine, but only a certain number are going to develop a problem with cocaine. And that has to do with the way their own biology and brain interacts. So we've been able to sort of narrow down like certain genetic profiles that make someone more at risk for certain substances. And then on the environmental side, early use, we've already talked a lot about that one. Chaotic home and abuse, there is some research on adverse childhood experiences. And what we know is people that grow up in traumatic households, just chaotic households, maybe they've witnessed abuse or they've been neglected, or even maybe it was just really stressful growing up. These things all make someone more vulnerable. One of the other risk factors that we certainly know about, if we think about reasons people use drugs and alcohol for medication, self-medication, or coping, is having a co-occurring psychiatric disorder. And we use the word co-occurring, meaning having both a substance use disorder or addiction and a separately occurring psychiatric disorder like depression or anxiety or bipolar. So the sort of co-occurrence of both of these things. And some of the time, the psychiatric disorder might predispose the person to using substances, but we also see the opposite of that, where substance use predisposes people to developing these types of co-occurring disorders. Particularly when we think about trauma, people that have had traumatic experiences and are trying to cope with their symptoms might use a substance for relief, but substance use also predisposes people to trauma because they might put themselves in higher risk situations while using or to obtain. Okay, so here's my next myth. Addiction is a choice, right? I hear this from family members of loved ones a lot of the time, right? They're choosing to use drugs over me, and that word choice, has a lot of meaning loaded into it. And the reality is that repeated exposure to a substance, so that regular use period, leads to changes in the brain system, right, involved in reward, motivation, and memory. And this is what makes it so hard to stop. Right? And I have the word substance or behavior because that can happen with other behavioral addictions as well. Repeated engagement in a behavior then leads to those alterations, and that's when addiction develops, and then it's hard to get back. So this is just a little bit more on this idea of heritability, particularly epigenetics. So somebody may not have any family history of drug or alcohol use, but they may develop a substance use disorder because of other risk factors. And that actually alters the genes so that then that risk is passed down. So the idea of epigenetics is the interaction between the environment and someone's genes, and it can actually sort of alter or express certain genes, which then becomes a risk factor. Okay, so here, this is looking at, again, this sort of progression. So when we talk about alcohol use, for example, plenty of people, we've already looked at the numbers, engage in social drinking, right? That in itself is not necessarily a problem. And then people might move into problem or abusive drinking. And that actually can be an opportunity for intervention, right? Plenty of people at that point, their family member, their friend may come to them and say, like, I'm really worried about how much you're drinking, or like the way you acted last night when you were drinking was not okay, or they may have a negative experience where they get a DUI, and then they stop, right? They say, oh my gosh, like I don't want to continue down this path. Like plenty of people who are not alcoholics have one DUI, right? Usually if you have like 2, 3, 4, and you keep engaging in that behavior, then we're looking at the progression of this disease. So there are plenty of people that intervene at this sort of problem or abusive drinking, and they have not sort of progressed into what we're talking about in terms of addiction. So then we move into dependence, right, or this altered brain function where using long enough has caused alterations in the brain that then make somebody lose control of their drinking or their drug use. And that's when usually we see people need treatment or intervention or support groups so that they can try to prevent a withdrawal, prevent a relapse. Okay. People won't stop using drugs until they experience enough consequences and hit bottom. Anybody heard this one before? Yes, okay. We hear this all the time, right? It hasn't gotten bad enough. They're not ready to change. Let me tell you, if consequences were enough to get people to stop engaging in addictive behavior, I would not have a job. We wouldn't have those overdose rates that we have. All of those people overdosing, they've had consequences, right? So consequences alone are not enough. That's not the problem. Using punishment or incarcerating people to deal with this problem doesn't solve it. We've seen that. We've tried that. So hitting bottom is totally a myth, and it does not have to happen because things will keep getting worse and worse. So the reality is that substance use triggers changes in the areas of the brain related to reward, emotion, behavior, and decision-making, which all contribute to continued use regardless of consequences, right? So it's those alterations in the brain that perpetuate the problem. And until we kind of understand that, we can really misinterpret what's going on with somebody. Most of the time, the patients that I work with tell me, that they've been wanting to change and thinking about changing for a long time, right? They've been concerned. They've had a lot of consequences. They haven't been able to do it. So you guys may have heard this idea of addiction as a disease, right? And this is really what we mean when we say that it's a disease, right? It is a chronic relapsing brain disease related to alterations in the brain from repeated exposure to drugs and alcohol. Treatment is possible, recovery is possible, but it is chronic, and it usually involves lifelong management of the disease. And a lot of this has to do, we talked with the adolescent brain, sort of these alterations and impairments in development, but this happens for adults too, right? Critical components and functions of the brain that have to do with reward and memory and learning are altered by repeated exposure to a substance. And it says on here they persist long after substance use ends. Usually we see around like 12 to 18 months of sobriety, of complete sobriety. Some of those improvements start to sort of take place, but it's getting somebody to 12 or 18 months that is what's so crucial. We also see that it's a progressive disease. And progressive in the sense that, again, it's disrupting those areas of the brain, and so then somebody continues to use because those areas have been disrupted and they've lost control, and then there's just sort of a vicious cycle, right? Maybe they get, a week, 2 months of sobriety, and then they relapse, and they're sort of back to where they started, and it continues to progress in consequences. When we think about it as progressive, we also think about the risk for something called cross addiction. So having a problem with one substance or behavior then actually makes somebody at risk for developing a problem with another substance or behavior. So you can, and this is timely, again, just related to the opioid epidemic, that we see people with, again, 40 times more likely to develop a problem with heroin if you've been addicted to opioid painkillers, right? So you may have heard people talk about sort of the crossover from prescription drugs into heroin. That's definitely a real thing, particularly as we see a crackdown on prescription drugs. But other drug use, alcohol, marijuana, cocaine, also leaves somebody at risk for developing a problem with heroin. And some of that has to do with the neural pathways that have been laid down. So if you're using one substance and sort of lay down some neural pathways related to substance use, another substance or behavior will take advantage of those neural pathways. Okay. So here's a little bit about sort of how drugs actually alter your brain. So what actually happens? Again, every drug, including alcohol, works a little bit differently in the brain. However, they all utilize the reward system. And there's several neurotransmitters involved in the process, but we talk about dopamine because it's always involved and it's kind of the easiest one to understand. So for example, you see here, right, that things like food, sex, exercise release dopamine in our brain, right? They are designed to do that. That has to do with survival. They're natural rewards, right? We want those things to happen so that you continue to do them. They're supposed to release dopamine and feel good. What happens when we use drugs or alcohol is it releases much more dopamine than your brain is accustomed to. So they use cocaine as an example here in this picture. So sort of your brain is flooded with dopamine. This is why people feel so amazing when they first start using, right? It feels really good. All of their reward lights are going off and it's like, feels amazing. But then what happens over time is your brain sort of gets used to that and then actually will alter its own reward system. So your brain might start producing less of its own dopamine, right, to account for the dopamine you're giving it, or it might shut down some dopamine receptor sites, again, to try to moderate how much you're giving it. And this is where people develop tolerance. So as substance use continues, people will tell you they really don't even feel that much pleasure from using anymore. They just want to feel normal. And this is actually what they're talking about. They're talking about just trying to have a homeostasis of dopamine. The other thing that kind of happens here is a reduced pleasure in normally pleasurable activities. So a level of anhedonia. Yes, going out to eat with my friends used to be rewarding and fun and release dopamine, but compared to cocaine, like that's not releasing any dopamine, and I'm really not getting any, anything good from that, right? So what that actually does is reinforce the drug use even more. Okay. So we talked about the reward system. There's a couple other areas of the brain involved in sort of the neuroscience of addiction. One in particular being the prefrontal cortex. And this is the area of our brain that is responsible for decision-making, impulsivity, executive functioning, all of those things that we use every day. And this is why relapse rates are so high. So this sort of third stage we see of addiction affects the prefrontal cortex. So even when somebody is motivated and they have support in place and they want to stop using drugs, because of the impairments in this part of the brain, the executive functioning, it's hard to do, right? They're much more impulsive at this point in time. Think about like they're kind of back to being impulsive like a teenager would be. And so they might have every good intention in the world of not using alcohol in that situation, and then alcohol is offered to them, and they're not thinking clearly, right? And it's impaired, and so they're going to say yes, and then they're going to regret it, right? And then they sort of start this cycle over again. So there's this sort of negative affect that occurs because of all of the alterations in dopamine. And then it's really hard to actually make better decisions in the face of that. So you're feeling worse, and then you have reduced executive functioning, and somehow we all expect those people to just like, pull themselves up by their bootstraps. And it just really doesn't work. And this is why I would argue we see such high relapse rates, because people don't understand this. And we judge people then. Oh, they just didn't want it bad enough. They weren't trying hard enough. They weren't serious about it this time. They didn't hit bottom. Well, no, actually, there is a really valid reason that they're having a hard time making these behavioral changes. And it has to do with something that we can't even see inside their brain. Okay. Next myth. People can stop using drugs if they want to. Right? We just kind of talked about that. So the fact is, the alterations in the areas of the brain responsible for executive functioning and stress management contribute to high relapse rates, regardless of someone's motivation for change. I would also argue that sort of regardless of their motivation for change, being in their environment, right? We're talking about that reduced ability to manage stressors, and that sort of reduced affect. So you put them back in a really stressful situation, it's more than they can cope with, and they don't have the skills to do it. So we have a little bit of additional data about some of the neurocognitive effects from opioid use, specifically reductions not only in sort of memory and impulse control, but also in concentration, and then also in stress resilience. And again, that goes back to putting people in really stressful environments when we're also asking them to stop using drugs and alcohol. If they've reduced their tolerance to stress, recovery is an incredibly stressful thing, and then we expect them to somehow be able to do it on their own. Some of the other just sort of neurocognitive changes we see from opioid use: the cognitive defects, reduced impulsivity, poor self-regulation, compulsivity, and then also a reduced cognitive flexibility. So in a situation where somebody feels really bad, with that reduced cognitive flexibility, it feels like I feel really bad right now and I'm going to feel bad forever, as opposed to being able to think like you or I do. I feel bad right now, but I know I won't always feel this bad. So they sort of lose that ability to see the future. Okay, let's look at some brain images now, just to give you an example. So what you're looking at here sort of is a control on the right that's looking at healthy brain activity, and healthy meaning there's a higher color density. So what you're looking for is more red being the highest level of activity, and then moving into yellow and then green. So on the right, we see a lot of healthy activity throughout the brain. On the left, we see overall reductions in activity, and this is from alcohol use. And so what we see in a lot of different types of brain scans is just reduced activity from heavy alcohol use. And that doesn't imply addiction, but that's what leads to addiction. This is the same type of image, but with someone using cocaine. And really, this one shows some of the recovery that we're talking about and how it takes time. So again, on the top, normal control. The bar graph on the right is just showing you like the level of activity. So the top red being the highest concentration of activity down to the blue. And with 10 days, that's 10 days of abstinence. That's what that means. We see that some of the activity is there, and then 100 days later, we really see improvements in the activity. So this is why a lot of times in treatment and recovery planning, we talk so much about getting people through the first 6 months to a year to 18 months, because we know some of these changes in the brain take place over time. Again, this is looking at activity only in one area of the brain. That's why it's only in that one area. Again, red being the highest concentration of activity. And we finally see there on the right with 14 months of abstinence from meth, a lot of that activity starting to come back. So this is, when we talk about recovery being like a long, ongoing process, this is what we're talking about. There's another type of scan. So those are looking at activity. There's another type of scan called a SPECT scan that also looks at activity. And what a lot of the research on this sees with like marijuana, for example, is decreased activity in certain parts of the brain. With alcohol, we see decreased activity throughout the brain. So like I mentioned, this is a different type of scan. So this looks like it's measuring density, but it's actually also measuring activity. So this is the healthy control. There's activity happening throughout the brain, throughout the cortical region. And then here is the unhealthy brain. Now it looks like there's holes in the brain. That's not accurate. That does not mean there's physical holes in the brain. What that means is reduced activity throughout sort of the cortical region of the brain. And this is from an alcohol user. And this actually is from an alcohol user that engaged, I think was in their mid-30s and engaged in heavy weekend alcohol use. So not even daily alcohol use. Here is another example of the same type of scan. And this is a marijuana user brain. And this is from a teenager. So a young person, and again, we just see those reductions, particularly in the front. So if the way that this is set up, the top is the front of your brain. That's the prefrontal cortex. So in the marijuana user brain, we see a lot of the reduction in activity in that part of the brain, in the prefrontal cortex. So we've been talking about addiction this whole time. Maybe it's helpful to have a shared definition, what I mean when I say addiction. And this is a fairly lengthy definition. But again, it's that inability to control behavior, continued engagement of something despite consequence, and that it is a brain disease related to reward, motivation, and memory. So if you remember anything from today, hopefully that's what you'll remember. I'll say it a lot. All right. Another myth. Only people who drink or use drugs every day have a problem. Fact. Substance use disorders are identified based on the consequences and impact on functioning from drug and alcohol use, regardless of frequency or amount used. Right. So if we remember back to the scan from the alcohol user, that was not daily alcohol use, right? So we're not necessarily, when we think about these alterations in the brain happening, it's not about frequency or even amount. A lot of it has to do with, again, those risk factors for addiction, and then also the quality of somebody's use. So how it's impacting them, what kind of associated consequences are they having? Every time they drink, are they getting blackout drunk? When they drink, are they having sex with people they wouldn't normally want to have sex with? When they drink, are they driving? Is marijuana use impacting sort of their relationships or school or memory? So we're looking at the quality of use, not just the amount. And the way that we do this clinically, if you're interested, is through something called a substance use disorder. So you've heard me use that word, and we kind of use those words, substance use disorder and addiction, interchangeably, because when we diagnose somebody, when they come in for treatment, we would actually be looking at this, a substance use disorder, an alcohol use disorder, a stimulant use disorder, to sort of look at how problematic it is. And there's actually 11 criteria that we use in these 4 categories within a time period. Now, a lot of times what people think of when they think of addiction is this 4th category up here, pharmacological indicators, right? Like, oh, I can't have a problem because I don't have a tolerance, or I'm not having any withdrawal symptoms, right? Those are 2 of 11 things that we look at when we look at somebody's substance use. So withdrawal is a very small part of it. People don't have to have withdrawal to have addiction. Okay, just a little bit on behavioral addictions. Maybe this picture looks familiar. He's got a lot of social media going on there, and I just kind of like it because I think we often assume that addiction is sort of isolated, again, to drugs like heroin and meth and cocaine, and that's how people get addicted. But what we actually know is the same parts of the brain, the reward system, that's hijacked by drugs is also hijacked by behaviors like social media, gambling, sex, gaming, technology, food. When they look at brain scans related to behavioral addictions and substance use disorders, it's the same areas of the brain that are involved. So yes, it is a real thing. Some of the most common behavioral addictions that we see: gambling, sex and love, shopping, video games, technology, food. When we think about social media and technology use, one of the things about drug use that's so reinforcing when it sort of hijacks our reward system is the fact that it's using intermittent reinforcement. Sometimes it's good, sometimes it's not. When you think about social media, how often people check their phones, how often everybody in here, and I'm guilty too, we check our phones because we're looking to see if we have any new messages, how many likes did we get. All of those things are reinforcing. And every time you look at your phone and you have likes, you're actually releasing dopamine in your brain, right? So it's the same process. Or with shopping, Amazon. Like when people get home and there's like an Amazon package, your dopamine's going off. And actually, there's a lot of science about sort of like an anticipatory high with drug and alcohol use, like thinking about using, right? Even if you haven't gotten to the bar yet and you know you're going to happy hour, you feel better, right? There's already dopamine being released in your brain. When you know you check your phone and that package is waiting for you at home, like dopamine is already going off in your brain. Just a little bit of statistics again about sort of smartphone addiction, just how often people are checking their phones. Pay attention how many times you're checking it. Again, it's very reinforcing. Now, I will also say like a smartphone addiction is probably not going to cause the level of consequences in your relationship as like other drug and alcohol use disorders, but I think it's just helpful to have some context that these things are using the same part of our brain. And then when we think about sex addiction specifically, this is one behavioral addiction we have a lot of research on. These are the things that we use to categorize it. And they're the same things we look at in terms of drug and alcohol use, right? Preoccupation, continuing to engage despite consequences, feeling like it's unmanageable. It's the same qualities. So some of the things that we look for when somebody does have a substance use disorder, right, for treatment, is treatment, I won't go over all of these, but is treatment that addresses kind of everything that's going on, right? So if you're worried about your drug use or you're worried about a family or friends, these are some of the things that we think to look for. Particularly when we think about relapse prevention, again, we've talked about like 12 to 18 months for the brain to repair. So a lot of this is about getting somebody through that crucial time while their brain is repairing. Okay, here's another common myth I hear. Once somebody relapses, it's hopeless to try and help them, right? I see families and patients all the time, like they've had a relapse or their family members had a relapse. They feel really discouraged. There's a lot of shame. They don't want to go back to treatment. They don't want to go back to meetings and let people know that they've relapsed, right? But if everything we've already said is true about sort of the science and what changes in the brain, then we should expect relapse to happen and be prepared for it. And actually what we see is that relapse rates for addiction are similar to rates for relapse in other chronic diseases. And this is where with opioids, some people might need medications to help prevent a relapse, right? Because we know it's the same. So this actually sort of gives a comparison. We see rates for relapse for substance use 40 to 60%. That's not that different than some of these other chronic diseases. Now, disclaimer, no, asthma is not breaking up families. People are not like engaging in illegal behavior when they have a relapse in asthma, right? So it's comparable, but not completely comparable. I would like to give that disclaimer. But it's relative in terms of how we think about it, and going back to why people don't seek treatment, stigma, right? So if somebody has asthma and they have a flare-up or a relapse, or come out of remission and they have to go to the ER, right, to get a breathing treatment, no one in the ER is judging them like, oh my gosh, you didn't manage your asthma well enough, you're an asthmatic. Like, we don't say that. But we do say that in the ER, right? We judge people, they're an addict, oh my gosh, they just don't care about their family. So that judgment and stigma is part of the problem. All right. So this is, when we think about, right, recovery being such a process, this is a little bit just sort of the timeline where we think about sort of people finally moving in to remission, and that's the goal, right? Sort of prolonged remission after seeking treatment. And the reality is most people will seek treatment more than once. Most people will try to quit smoking more than once before they're successful. It's the same idea. And then here we go. This is one of my favorite images because I think when people come to treatment and when their family comes to treatment, on the left is what they expect. Like, oh, my family member's coming to treatment, you're going to fix them. I hear that word all the time. You're going to fix it, and then they won't need to have this problem anymore. Somehow it's going to like go away, and it's going to be easy. The reality, again, on the right, is it's a very messy process. Many people relapse more than once. The goal is an upward trajectory, right? Moving people towards recovery, but also having an expectation that it may take sort of a while or more than once. And when we think about recovery, we think about a lot of factors needing to be in place. We think about recovery as an ongoing process, not just the absence of drug and alcohol use. So again, thinking about everything we've talked about in terms of the science, just removing substance use is not enough. It's all of these other quality of life measures that we're looking at. It's adding things to your life that are rewarding, that are fun, that are enjoyable, adding positive social supports, really engaging in a lifestyle of recovery. And I think maybe we'll stop here and have questions. Does that sound? Yeah.
just kind of turn it this way. Okay, thank you. If you have questions, please feel free to come up to the mic so that those that are watching the live stream and the recorded version can hear the audio.
Hey, thank you so much. I thought it was incredibly interesting. One of the things that you spoke about was the chemicals in the brain and the way that the brain reacted and the patterning there. And so I was wondering, because then you also talked about behavioral. And so I was wondering where we could see that transition. You get that same kind of reward system. Wondering if someone were an alcoholic, then they went to a recovery group such as like Alcoholics Anonymous, if they're still getting that same reward system and that their brain hasn't really changed.
So part of what we would say, like an overall recovery, would be engaging in other things to try to find other rewards. So like exercise, support groups, like healthy relationships, because what you're trying to do is rewire your reward system and also like fill your time with other like rewarding activities that will hopefully then sort of change the template in your brain. Yes. So that's why you might see people early in recovery like get really into like extreme sports or like exercise or other things like that, because they're trying to release a lot of dopamine and like feel good again, just in healthier ways. We also see like with programs like AA or Narcotics Anonymous or Smart Recovery, a big part of the reward there is the relationships. And again, our reward system is naturally designed to be reinforced by relationships and attachments. So yes, that's often why those programs are so successful. Any other questions?
Question is really if you recommend any books or authors. I know that, being a treatment provider, we try and work with the families.
Yeah.
So any, resources that you recommend for family members maybe to be a helpful support.
Yeah. Absolutely. So there's a couple things for family members I recommend. One being getting their own therapist. If you're worried about a loved one or dealing with this in your family, getting your own professional help, like a counselor that can help you figure out how to set boundaries, manage your own stress, and have realistic expectations. A great free resource is Al-Anon. So Al-Anon is a anonymous support program designed just for family members of individuals with drugs and alcohol, and they have great data on their outcomes for people that participate in that in addition to therapy. And then a book I really like, if this is of interest to anyone, it's called Beyond Addiction. And Beyond Addiction talks about how family members can actually use like behavioral change to reinforce and help someone address their substance use. So it takes a different stance than like being punitive or like kicking people out. It's much more about how to reinforce change.
Behavior. And that's kind of where my question comes from is how do you start incorporating changing the situation or changing the situation when you're going through treatment? Because I mean, when they walk out the door, they're going right back into the environment that basically has put them there.
Yeah.
So how do you start fostering that kind of stuff, and how do you teach them that?
So the first thing would be to try to keep somebody from going right back to their environment. If we again think about this in terms of like reward and motivation and reinforcement, people are conditioned to use substances in their environment. Even people who've been in recovery for a long time, they might walk into a bar or restaurant where they previously used, and they might get an automatic thought about using because they've been conditioned to that, even though they don't have any desire. So part of treatment is helping people figure out how to manage that. But then we know it's hard to manage that because of the sort of damage to the prefrontal cortex, right? So this is why we talk so much about changing the environment in terms of like sober living, halfway houses, recovery residences. All of those types of things have a lot of good data because it's taking someone out of that environment for a longer period of time to give their brain time to heal. Honestly, like if it's possible, removing someone from that triggering environment for as long as possible helps prevent relapse. That's not always feasible. So if somebody has to go back to the situation, we talk about like accountability measures and structure and support that would help put kind of some scaffolding in place that's not there with their own prefrontal cortex at that point in time. So that might be like drug testing, recovery case management, recovery coaching, things like that kind of act as sort of executive functioning for someone while it heals and develops. Does that answer your question?
Yeah, it's kind of a difficult situation because it's just kind of like a circular.
Yeah. Mm-hmm. And that's why I also say for family members, like doing their own therapy, their own work, being involved in their own recovery program. So as you change, you are helping your loved one change. Mm-hmm. And just getting support for yourself as you deal with a difficult situation. Mm-hmm.
Question real quick. It's two questions actually. How are cultures affected differently in addiction? And also how are the sexes affected differently?
Can you say more about culture, what you mean?
Are certain cultures more predisposed to addiction than other cultures?
Yeah, so there is some myth out there like that certain cultures, like Native Americans, for example, might have higher rates of addiction for a biological basis, but actually that's hard to flesh out because if we think about it in terms of adverse experiences and like trauma and intergenerational trauma, it's hard to know. We would think that that's actually like an environmental risk. So, if they have repeatedly been discriminated against or marginalized and live in a state of stress, then we would think that in itself is a risk factor for addiction. And so they might be disproportionately impacted. Does that kind of answer what you're asking? Yeah. Mm-hmm. Absolutely. And then in terms of gender, just statistically speaking, we see higher rates of addiction in males than females. There's a little bit of research on risk for developing addiction in terms of people being more risk-taking. One of the risk factors in terms of like psychiatric disorders is ADHD. So people that tend to be more impulsive, naturally risk-taking, have a lower threshold for sort of danger. Those people tend to be higher risk for developing addiction. So we might see that more in males. Mm-hmm.
Thank you for your presentation. And one of the most interesting parts of it to me was the epigenetic piece. So if I understood it correctly, the evidence is that sustained living in addiction and repeated exposure to alcohol or other drugs causes epigenetic changes that make it more likely that I will pass on the addiction. So here's the question, and it goes to motivation for recovery. Is there evidence that abstinence and recovery provide protective factors epigenetically for the next generation? Because if there is, it could be a motivation to engage in recovery.
I haven't seen any specific data on epigenetics as a protective factor, but there is a lot of research on general protective factors. So even if there's a family history of addiction or a parent that had a substance use disorder, there's a lot of research on protective factors like healthy attachment, school engagement, sort of peer group, stress management, like reducing stress in the home, modeling healthy stress management. All of those things are demonstrated to reduce risk. Whether or not those would alter the gene expression, I don't know. Mm-hmm. Any other questions?
Okay, well, thank you, Ms. Gilmore, for joining us today. Please, let's show our appreciation. The other thing, I believe the ladies from the Women's Fund have passed out some evaluations on the chairs. If you please take a moment to complete that evaluation and turn it in at the table at the back of the room. Also, feel free to stick around and ask any other questions if you'd like to talk one-on-one with Ms. Gilmore or anyone here. And we thank you for participating and for attending. Have a great afternoon.